the actions and the liver. We're going to dwell more on hepatitis virus because that's the focus of even today, the entire world. The World Health Organization brought the entire world under one theme, this very theme, to discuss about viral hepatitis, basically. Because the focus here is to raise awareness in knowing the global body of viral hepatitis and also to stimulate or to see that actions taken to cause a change in terms of treatment, in terms of screening, in terms of ending the aspect of stigmatization, and of course, in the policy end, to talk about fundraising. So the other factors we talked about, I made mention of some infections. Other organisms like the cytomegalovirus, adenovirus. These are other organisms, the Epstein-Barr. These are other organisms that have been associated in inflammatory processes in the liver. Now, talking about toxicants, when you have a high amount, heavy level of alcohol could cause hepatotoxicity and could cause hepatic damage. And then you also have drugs, medications like acetaminophen, that's paracetamol. The OTC drug is also known to be hepatotoxic and can also cause inflammation of the liver. You also have drugs like the anti-lipidemic agents like statins, cholesterol-lowering drugs. You also have the drug like isoniazid, the anti-tuberculosis agent. You also have antibiotics like nitrofurantoin, like the amoxicillin clavulanate combination has also been found to cause inflammatory reactions in the liver. Now, besides that, we also now have certain conditions, certain disease conditions, like autoimmune diseases and genetic abnormalities that have also been associated with inflammatory processes in the liver, as in hepatitis. So now we talking about alcohol. I just want to talk a little about alcohol. Besides using, in consumption of heavy amount of alcohol to cause hepatotoxicity, severe hepatic disease. If individuals consume alcohol, that's heavy alcohol consumption, does not just cause acute liver failure. It also results, it actually causes chronic liver disease, which is a major concern. Because in the disease pathology or the pathophysiology of hepatitis, like I said earlier on, now you have the inflammatory reaction, inflammation that occurs. Now, oftentimes, because we say it's self-limiting, some individuals that will come down with hepatitis may not even have symptoms. Generally, a good number of them may be asymptomatic. But in some conditions, in some acute situations, they may come down with certain symptoms, which oftentimes will not express with the typical hepatitis symptoms. Symptoms like fever, malaise. You have symptoms like anorexia, that is loss of appetite. You talk about nausea, vomiting, and then you talk about, and now if you look at all these initial symptoms now, you find out that they have a strong resemblance of that of malaria. And that's key information for pharmacists, such that, when individuals or patients present with symptoms of this kind, we should not, be in a hurry to settle down at malaria or typhoid fever, as the case may be, and then begin to place them on medication. As we proceed further, you will understand why. But besides these symptoms, we also have conditions that may be now defining the condition more, wherein you have dark urine, you also have the yellowish coloration of the eyes, and then of the skin, which is jaundice.
Today, she's a board of member of APO, that's International Alliance of Patients Organization, and a listed member of British Charity Trust. As a fallout of COVID-19, she also initiated the design study protocols for COVID-19 response in Africa, with at least 4 peers review over the asset journals publication of COVID-19. On several work she has done on hepatitis, in September 2016, she was among the 25 women worldwide invited to the inaugural Women in High Places Hepatitis in New York. And of course, she has also emerged as a global change maker 2017 in hepatitis C, an international recognition awarded to her by the Economist Intelligence Unit. She has received several letters of recommendation also from the presidency at Aprioku on She has also trained so many people on hepatitis champion. And recently we also introduced liver health and workplace policy. And of course, finding the missing millions living with viral hepatitis, mother to child transmission, and of course, several awards have been given to her in that regard. For Live Well initiative, we have also doubled as a finalist in nomination against other multinationals on several work they have also done on hepatitis. Mrs. Bisi Bright is happily married with children and grandchildren, and to the distinguished pharmacist this afternoon, permit me to open the floor to pharmacist Bisi Bright. Thank you very much.
Thank you very much. Pharmacist Mrs. Bisi Bright, the floor is open for you for the next 30 minutes. Your mic is muted. Pharmacist Bright, unmute yourself.
Good afternoon. Good afternoon. I'm really sorry. I'm really sorry. Just being lost today. Good afternoon. I don't know whether I'm supposed to speak now. Please, I don't know. Hello, good afternoon. Good afternoon, colleagues, ladies and gentlemen. Can you hear me? Good afternoon.
Yes, we can hear you now.
Okay. I don't think you are connected to the Zoom link because your voice is echoing from a distance. The voice is sounding like you are in a room, but you are not part of the Zoom. I don't know what to say. Hello, Madam Ijoma. Good afternoon. I don't know what's happening. Am I supposed to speak now? I can hardly hear you. I don't know what's happening. I can hear you from a distance, not on the Zoom meeting. I can hear you from a distance. I don't know whether the meeting is on. That's what I'm asking. I don't have any problem with my... No, I don't have any problem here. I've been speaking at Zoom meetings all day. I don't have any problem with my device here. If I'm the one speaking, I should be in the center of the screen. That's why I'm asking you. That you have not handed over the floor to me. Okay, someone says the meeting is on. Go ahead. Okay. Okay, good afternoon, colleagues, ladies and gentlemen. I'm sorry about the confusion. I was told that I'll be speaking at 2 o'clock, and then it was moved to 3 o'clock and then 3:30. So, but all the same, I want to apologize for whatever logistics challenges there were. I came into the meeting room twice earlier, and I didn't know what was happening. That's why I left. I came in around just after 2 because I had another webinar, and I had explained to Pharmacist. Anyway, it's a privilege to be here. Thank you very much. Happy World Hepatitis Day to all of us. I'll now share my screen. Thank you. The title, today is World Hepatitis Day, and the title of today's lecture is Hepatitis Can't Wait. As you can see from my background here, that is the slogan by the World Hepatitis Alliance, and that is the slogan that is being used all over the world today. I want to apologize once more that I came in late for this meeting, but when Pharmacist Ijoma approached me, I actually told her that I had other meetings and I was speaking, and we just agreed on the 3 p.m. slot. So whilst I apologize, I also wanted to know that I have very great respect for my colleagues, and it's because of the overlap, and we were trying to work it out. So the title Hepatitis Can't Wait, for the first time since World Hepatitis Day has been marked year in, year out since July 28, 2011, when the first World Hepatitis Day was declared. For the first time this year, everybody is using the same theme without modifying and using the same logos and everything. Usually, when the theme is declared by the WHO or the World Hepatitis Alliance, each person modifies the theme to suit themselves. But there is an urgent need now, and so the whole world came together and everybody decided to use this logo behind me and use this same theme and everything. So the WHO, the World Hepatitis Alliance, the Federal Ministry of Health, and a lot of other organizations decided to follow the same thing without really adulterating it this time and without stretching it in different directions so that the focus remains the same. So thank you very much. It's a privilege to be here with us today. Now, hepatitis can't wait. Why can't hepatitis wait? You know, the theme, hepatitis can't wait. Why can't hepatitis wait? That is the question that I will try to answer today. And I will try to answer it from the point of view of what is happening globally today and how relevant it is to us pharmacists. Of course, we adopted it to our own, it's like PSN taking a lecture and putting their own logo. So we put our logo, which is Live Well Initiative, and the Women in Hepatitis Africa, which is one of our subsidiaries, and Giant, which is our COVID, our subsidiary in the time of COVID. So I'll first of all start by quickly explaining our portfolio, and it is relevant to this lecture because we are talking of retooling pharmaceutical care for pharmacists so that we can see a relevance in hepatitis and these infectious diseases and even a lot of other public health issues where we see how we can fit in as pharmacists and how relevant it will be for us. So the Live Well initiative, I've put this in the slide, is part of the retooling, but I'll just explain it quickly. The Live Well initiative is a member of the United Nations Global Compact, we're a member of the World Hepatitis Alliance, we're a member of the International Alliance of Patients Organizations, the African Hepatitis Alliance, and so on and so forth. And we have academic relationships with some institutions of higher learning, like as an institution, as an organization, Live Well is in relationship with Harvard University, and I'm a trainer in their faculty. We're also in relationship with the University of Helsinki, and I train on their faculty, and so on and so forth. But I'm going to mention more about this later, not in relation to Live Well, but to show that these are some of the things we need to do our retooling. So today is World Hepatitis Day, and this is just a brief history of the World Hepatitis Day. Maybe I don't know whether I should make the slide smaller because with the full screen, some of the titles are not showing well, I don't know. Well, if it's okay, I can continue. Okay, so a brief introduction into the World Hepatitis Day. The World Hepatitis Day was declared for the first time on the 28th of July, 2011. And every year since then, on the 28th of July, the World Hepatitis Day is marked. It's an annual event which provides international focus on patient groups and people living with viral hepatitis. And it provides an opportunity to focus on various specific actions such as strengthening the prevention, screening, control, and vaccination or even treatment of viral hepatitis and its related diseases. And also it helps to increase coverage of viral hepatitis and the coordination of the response to viral hepatitis. Now, the reason for the title this year is that hepatitis was grouped under HIV/AIDS globally. And I'm sure all of us are aware of the Global Fund for response to HIV/AIDS, TB, and malaria. But they now grouped hepatitis under HIV, and all the funding for HIV, if they had 10 naira, they would give 9 naira 90 kobo to HIV and give 10 kobo to hepatitis, which was not enough for anything. In fact, I know I've apologized for being late for this meeting, but I will be explaining as I go along. In fact, this morning, the WHO country rep for Nigeria, when speaking at the Federal Ministry of Health Hepatitis World Hepatitis Day event, said that in the whole of Africa, only 1% of the people living with hepatitis C are receiving treatment. And those with hepatitis B, 1%. And those living with hepatitis C, nearly 0% are receiving treatment. Whereas the official position in Nigeria is that the Nigerian government subvents hepatitis C treatment. They give stuff and dark. I think the patient is supposed to buy the dark and then he's given the substitute. But you find out that if there are 200 patients, maybe only half a patient gets it. That means that one patient gets it this month, doesn't get it next month. That's why it happens. So it is so bad. The access to care for hepatitis patients is so limited. It's so limited. So for us in our own organization, over the past 8 years, we've screened 60,000 people for hepatitis B and 50,000 for hepatitis C. Now, I'm including the COVID years anyway. But you see a lot of organizations saying they screen 500,000 people, they screen 200,000. But if you check very well, they are just throwing figures because It is not so easy. If you follow the protocol for screening for hepatitis, it will take you 15 minutes to screen one patient. So if you say you screen 200,000 patients, in how many months or years did you do that? So these are real figures that we're giving us here. And then we've run a lot of advocacy, screening and vaccination programs in Abuja, in Lagos, Asaba, Ibadan, Ilesha, and Kaduna. We've also run corporate health programs. We find out that people in the corporate world, they don't really know much about hepatitis. And we've done a lot of corporate programs at FSDA, GT Bank, Stanbic, and so on. We've trained over 4,500 women champions in hepatitis from 18 African countries, including at least 100 members of ALT and at least 70 IPSS members, student members, student pharmacists. And in Egypt, we trained 450 lady pharmacists in Egypt as hepatitis champions. So in all, we've trained almost 600 pharmacists as women champions, lady pharmacists as champions in hepatitis. And here in Nigeria, we've trained about 3,500 women of all disparities, including low literacy women. Unfortunately, I won't be able to show you the picture. I actually dashed down to our office quickly to take a picture with some of our low literacy women that we have trained. And they were all wearing the hepatitis can't wait mask today. But they haven't sent me the picture that I've shown us. Anyway, so in Nigeria, we trained over 3,500 women, of which at least 150 of them are low literacy women who've never been to school. And we run a women's wellness center for hepatitis in Makoko. So pharmacists can do all these things. That's the point I'm trying to make. And then we do a lot of research and surveillance into viral hepatitis, among other diseases. And we're in partnership with Harvard School of Public Health on a project in hepatitis prevalence in Makoko, which is a low-income part of town, the low-income suburb. This picture actually shows, I'm sure we all know that lovely lady in that picture. And I remember she was one of the first lady pharmacists that came for our hepatitis training. But this class was a mixed class, which is what we normally do. We had hairdressers, we had one or two physicians in that class, some pharmacists, some nurses. We had two directors, two assistant directors of the Federal Ministry of Health, and 6 office officials from WHO in this particular class. So it was a mixed class. We also had widows, young women, and of course, older women, low literacy women. It was a mixed class, and that's the peculiarity. We can use the same course material to train everybody irrespective of their literacy level. So this was our program on the first World Hepatitis Day, 28th July 2011, and we had a work and advocacy work in partnership with MegaCare, pharmacist Yinka Oredola. So you can see that pharmacists have always been involved in viral hepatitis, and we can be involved and do a lot of work. That was a very nice collaboration because we did a lot of advocacy, screening, and vaccination. But I will talk about it later under CMM, Complete Medication Management, where the pharmacists, you don't work in isolation, you don't work in silos, you must work with other team members. So even this particular work, which was 10 years ago, we actually had physicians on our team, we had nurses on our team, but they didn't join us in the work. The work was just between Live Well and MegaCare. But when it came to, and we did the screening, so when it came to vaccination, we brought in a nurse and we had to get a physician to prescribe the vaccine and all that. So because it's always good to make sure that one does not run foul of the law. So what exactly is hepatitis? I know we are all pharmacists. I'm not going to waste too much time telling us what hepatitis is, but I just feel that taking a lecture of this nature would be incomplete without putting that. So I will just race over this. Hepatitis is just gotten from the Latin word, which means inflammation, and then it has to do with inflammation of the liver or injury to the liver. And you know, the liver is a very key organ, and it's also the largest organ in the body. So hepatitis makes the liver to stop working well. And when it's damaged, the tissue of the liver starts to give way, and we call it fibrosis. You know, it becomes fibrous like a sponge, and it might advance into cirrhosis, which is advanced fibrosis comes into cirrhosis, and then from cirrhosis it can lead to cancer. So it is a very, very life-threatening disease. And then it is something that is more common than we thought it was. For example, 90% of people who suffer from viral hepatitis are not aware. They don't even have symptoms at all. And Nigeria, I remember when we started marking World Hepatitis Day, they were saying that the prevalence of hepatitis B in Nigeria was 12% and hepatitis C was 4%. But now that the WHO and the whole world is doing all the epidemiological survey and getting the data, they've given us current data, updated data, which says that prevalence of hepatitis B in Nigeria is 8.12 and hepatitis C is 1.1. So we even used to think that hepatitis B was just 3 times more prevalent than C, but I can see it's almost 8 times more prevalent than C or 7 times more prevalent in Nigeria. C is more common in the Western world, and the B is more commonly transmitted vertically by from mother to child in the womb or through or children who get it get hepatitis as children, either through infection, maybe the acute hepatitis. If it's not properly and completely treated, it can now transform into a chronic form of hepatitis. Any form of hepatitis that is more than 6 months old is now chronic. Then the data returns show that states like Nasarawa and Taraba in Nigeria have very unusually high prevalence of viral hepatitis. In fact, the current president of, I'm actually the deputy national coordinator for viral hepatitis in Nigeria, but our national coordinator is from Taraba State, and in Taraba State they have 19% prevalence. So I think Taraba has the uniqueness of having the highest prevalence of viral hepatitis in Nigeria. But luckily, the national coordinator is from there, and he has just been elected as a president. He is president-elect of the World Hepatitis Alliance, so he will soon be going to the headquarters in the UK. So that's a very good one for Nigeria anyway, that one of us has been elected to the #1 position globally. So hepatitis may occur with little or no symptoms, and many times even the physicians cannot diagnose hepatitis properly because they use the liver function test, which is wrong. Unless advanced fibrosis has set in, the liver enzyme will still be normal. So if a person does a hepatitis screening using a rapid diagnostic test kit, and the person gets a positive test, that person should go to a virology laboratory for a confirmatory test, and not to, you find people saying, I'll go to my hospital, and they start mentioning brand names of, very sophisticated hospitals. But you see, if those hospitals do not have a virology lab, they cannot detect the viral DNA, and so they will not know. And hepatitis in particular has a DNA, it's a DNA virus for hepatitis B. C is an RNA virus. So it's very important that we know that the LFT alone does not show when there is hepatitis. And by the time the LFT starts to reveal that there is a distortion, then it means that person has probably gone into very, very advanced fibrosis or even cirrhosis. So when a hepatitis is less than 6 months old, like I said, it's acute hepatitis and it's usually treated and it can be resolved. But if it's allowed to last more than 6 months, it's going to bore deeper into the liver parenchyma and it may become chronic hepatitis. Now, there are different types of chronic hepatitis, A, B, C, D, E, but the commonest are B and C. Hepatitis D does not come on its own, it comes as an offshoot of hepatitis B. And hepatitis E comes as an offshoot of hepatitis A. So B and C are the most significant that we need to talk about. Now, hepatitis may be designed for up to 20 years or even another 10, even when they make a diagnosis, it may be designed for another 10 to 30 years after that, and then the person just ends up with cancer of the liver or something. So early detection is very key. And as pharmacists, we have a key role to play in early detection. I will tell us how and where. Now, types of hepatitis, I'll just say A is foodborne, the orophycal route. B is through infected blood, semen, and other body fluids, but vertically transmitted most of the time, and through mother to child. And then horizontal transmission can be by sexual intercourse. You can also have horizontal transmission from child to child. That is very common in Africa. Children are playing in the school. One has a bruise, the other one falls, and then they just get their body fluids mixed. They can just contaminate each other, and that's it. So there's a lot of horizontal transmission, even from child to child, not just vertical from mother to child. So hepatitis C is also transmitted by infected blood, and then a lot of grazing practices. Sexual transmission is possible, but you have a lot of we have a pharmacist who is working with special populations, men who have sex with men, and so on. All those special populations, hepatitis C is very common among them. Drug users, people who share needles, and so on. Like I said, hepatitis D does not occur without B. It's called the hepatitis delta. If I now that we have COVID and they are saying delta strain is difficult, I say wow, because both hepatitis D and E are so difficult. They're unusual, but they're very difficult. They kill very easily. There are complications from them very easily. People who have fulminant hepatitis, it could have started with hepatitis A and it just turns into fulminant hepatitis E and so on. So the causes are so many. I've mentioned that I won't dwell on that. I know we are all educated and we are all enlightened, and I can't teach anybody more than I know here. We all know. So look at the healthy liver and then the inflamed liver, the infected liver. Now, if you look at the symptoms too, talking of symptoms of viral hepatitis, there are so many different symptoms anyway, depending on the stage in which the person is and so on, and what type of treatment the person has received earlier on. So I won't even want to talk about symptoms either. And the reason why I don't want to emphasize symptoms and treatment is that with viral hepatitis and infectious diseases generally, many infectious diseases are notifiable. For example, you see that COVID-19 is a notifiable infectious disease. Even viral hepatitis, although it is not notifiable, I don't think anybody should be treating viral hepatitis without working with a government institution so that government can capture that data. And I also believe that once a person starts having symptoms of the liver, then I think it goes beyond the reach of the pharmacist, even if you're a clinical pharmacist. I'm a clinical pharmacist. Even if you're a clinical pharmacist, I don't think it's within your reach to be treating viral hepatitis. It's a chronic condition, and the liver needs to be examined thoroughly. So you will now need to start collaborating. You need to send to the health system. I don't even think it's the duty of a GP physician to treat either. So I won't, for those reasons, I'm not going to emphasize the symptoms. But the severity of the disease depends on how damaged the liver is, and then any other comorbidity, and so on and so forth. So, but this is better done by the physician who's going to make a diagnosis. And many general practice physicians also end up with misdiagnosis of viral hepatitis because they may not really have the training. And what you need in handling viral hepatitis is a gastroenterologist hepatologist. So that's part of what we're talking about, that it is very important that we know when to refer. It takes nothing away from us when we refer. It even adds to us because it helps us to now build up collaborations and work in teams. And that's the beauty of it. It's a very beautiful thing to do. So I also want to talk about seroconversion. It's very important to talk about this because there is an E antigen. Some hepatitis B viruses have this E antigen, which, you know, the antigen is the virus, and then your body produces the antibody. But some of the B viruses have the E antigen. Now, those that have the E antigen, when people get infected with that, many times they naturally seroconvert after some years. And we had an example here in my organization. One of our student members came down with viral hepatitis B, and we had her screened, and we wanted her to go and do her viral load count and all that. Sorry, it seems like there's a problem. I don't know. Hello? Sorry, I need to take a call. Is the coordinator calling me? Yes, please.
Yes, sorry, yes, yes, please. I'm sorry, I'm
I realized I was the coordinator calling me. That's why I picked the call. So No rudeness meant, please. Thank you. I've been told I have 10 minutes more, so I'll try and round up very quickly. Yeah, so as I was saying, there's something called zero conversion, and a lot of people do zero convert where they are positive and they now become negative without any treatment. And we had such a case in my organization. So it's very important that we as pharmacists know that a patient who tests positive may not necessarily be placed on drugs. When the person tests positive, they need to check the viral load count. And then from the viral load count, they will now know whether the person needs to be given medication or not. And then some of them just zero convert, especially those that have the E antigen. So I've talked about the fulminant hepatitis earlier on. Now talking about treatment, hepatitis C used to be cured in about less than 10 months usually. In fact, these days they're curing them in 12 weeks to 24 weeks with the directly acting antivirals, which are new drugs. And then well, for hepatitis B, it can be controlled but not cured within 18 months. But early detection is key, like I said, because people can incubate this virus for up to 20 years without even manifesting symptoms at all. So screening. Now, talking of pharmaceutical care, which is what they wanted me to go straight into. Now, pharmaceutical care is actually a theoretical framework. It is a theoretical framework designed for pharmacists, and it helps to operationalize patient care as it relates to the pharmacy. So it brings to mind the clinical and patient-centered aspect of the pharmacy profession. But it is a framework, so you need to operationalize it. So when you say that someone is delivering pharmaceutical care, you cannot deliver a framework. You still have to operationalize that framework. So in terms of pharmaceutical care for hepatitis, you have to look at what are the clinical services that a pharmacist can deliver in line with viral hepatitis. And when you're talking of pharmaceutical care, those clinical services have to do with medication therapy management, and it ends up culminating in what we call complete medication management. So CMM is a teamwork, and it results in best care outcomes for patients in the drug use process. So talking about CMM in the management of viral hepatitis, all new babies should be vaccinated at birth and within 24 hours of birth. So you now talk about commodity security. I really don't know how many pharmacists are very well versed in commodity security, but it is our duty as pharmacists, it is a part of public health logistics, that all those public health goods should be made available at all times. And so the word security imputed is a UN terminology for those products, to make sure that at no point in time have you run out of them. That means every health center, every birthing facility must always have the hepatitis B first dose vaccine. That is part of our retooling as pharmacists, where you make sure that you retool yourself with your commodity security framework. That's part of the pharmaceutical care. You know, I told you the pharmaceutical care is a framework. So your commodity security, what is your framework for commodity security? How do you procure those essential, you know, the EMS and the CS under the UN, as the essential medicines and the commodity security? Very, very important. Then enlightenment programs should be carried out to educate people on how to avoid high-risk activities and so on. And then safe and effective and affordable vaccines should be made available, especially for the newborn babies. Now, there are different types of vaccines. You have the birth dose vaccine, which is given immediately at birth or within 24 hours of birth, and should be repeated at 6 weeks, 10 weeks, and 14 weeks after birth. Although in low income and low resource economies, they say give at least 2 more doses after the birth dose, you know. So then for infants, you give booster doses. Then adolescents and children should be screened. That is the new thing now. They should be screened for viral hepatitis, and if found negative, they should be vaccinated. And then, of course, we have the birth dose and the adult dose vaccination, which is 3 doses. You have the first dose and then second dose after a month, third dose after 6 months. Although there is another accelerated dosing now where they give the first dose on day 1, second dose on day 7, third dose on day 30 or a month after the first dose, and then a year after they now give a fourth dose. That is the accelerated hepatitis vaccination. As pharmacists, we need to be updated, we need to know about all those things and teach ourselves. If you're in community practice, you have to make sure that maybe you have to work in a collaboration team, work with nurses, work with physicians, and make sure that you're able to do that. Because I've noticed some pharmacists just screen and then they refer to a physician. But you need to have a complete cycle. It was one of the things that was brought up at the WHO webinar today, which is the one I attended just before coming here. The people who are screening without having a complete package are doing the wrong thing. So when you screen, those who are negative, you must vaccinate. Those who are positive, you must refer them for viral confirmatory testing, confirmatory diagnostic testing, the viral load count, and then further treatment, linking them to care. So all persons who wish to be vaccinated must first of all be tested. And then there are those babies that are born to mothers who are already positive. Some of those mothers are already aware, but they did not receive treatment. They did not receive any prophylactic treatment because there is prophylactic antiviral for women who are pregnant and are suffering from hepatitis. It used to be lamivudine, but lamivudine is not very safe for the baby, the unborn baby, so they don't use lamivudine anymore. But there are prophylactic antivirals for the mother, and then when she delivers her baby, she will now get her own full treatment. For that baby that is born to her, must be given an at-birth immunoglobulin within an hour of delivery. So the immunoglobulin is even different from the HBV, the birth dose vaccine. So the immunoglobulin is recommended strongly for babies who are born to mothers who are pregnant and they have the viral hepatitis. For example, if you look at this slide now, it says that Adana cannot wait. And Adana had passed hepatitis B on to her children without knowing. So look at that boy that is sitting on her lap. The boy is living with hepatitis. So if left untreated, these children may grow up into adults that will eventually have liver cancer. So Adana needs to get her children screened and then treated if necessary. And she herself too needs to be treated. Remember, it's a chronic disease. A person can have it for 20 years without knowing. And then to the left of the screen, you see Lisa. Lisa could prevent her baby from getting viral hepatitis later in life. She is given prophylactic antivirals, and then that baby is vaccinated at birth and given also the immunoglobulin immediately within 1 hour of birth. In fact, in the US, they give women who are pregnant hepatitis B vaccination. I think that is dangerous. But the Americans, they do a lot of things that we dare not try here. So now, as part of our retooling and why we pharmacists cannot wait and we should not wait. Number one, we should embrace complete medication management. I've mentioned the things we need to do. When you're talking of your CMM, it has to be complete. We need to go and learn more about CMM. It's a collaborative thing. You can't work it out alone. You're going to have nurses on your team, you have physicians on your team, and you're all working in the best interest of the patient and with the patient at the center. Then talking about commodity security, I've emphasized the importance of having the birth dose vaccines and the importance of working very well with your essential medicines and commodity security toolkit. We work very well with Yaba local government, Pharmacist. She's been very helpful, and she is very versatile. She makes sure that she does the needful, and I like the way she manages it. You see that all those things, when it comes to commodity security, they get it well done in their local government and so on. So, and then when it comes to reproductive, maternal, newborn, child health commodities, which are also classified under commodity security, you need to update them. And I'm suggesting, in my own humble way, that the birth dose hepatitis vaccine should be enlisted under RMNCH. There are 13 commodities, the RMNCH commodities, and of the 13, 4 of them are the childhood commodities, and the remaining 9 are for the mother. So I'm adding another childhood commodity to make it 5, the first dose hepatitis vaccine. And I will not be surprised if by next year the WHO has revised that list to accommodate that. Then pharmacists also need to retool by arming ourselves with patient engagement and co-creation. These are all new things. You know, in those days, the patient had no voice, and there was a screen between the pharmacist and the patient. Now we've removed the screen, and we are saying we brought a framework called pharmaceutical care. But in implementing that framework, you operationalize it. So you have CMN, you have patient engagement and co-creation. Because patient co-creation is not really pharmaceutical care, it's just part of complete medication management. Co-creation means you are allowing that patient to have a say in what they are doing. Now, the International Alliance of Patients Organizations, to which I belong, the patients say there's nothing for us without us. And they are so powerful, they are in relationship with the WHO and so on. And so we as a patient organization, we've seen that the patient movement is a very strong one. And everybody who wants to be a relevant healthcare professional tomorrow must align with the patient movement today. So patient engagement and patient co-creation. Now we have patients who are expert patients. Just like you have a consultant physician and a consultant gastroenterologist, hepatologist, we now have what they call patient experts. And those patient experts are either patients or patient organizations who are experts in patient matters. So they are also calling themselves consultants, just like we now have consultant pharmacists. We now have consultant patients. It's just that they're not calling themselves consultant patients, they're calling themselves patient experts. So as a pharmacist, if you don't know who the patient expert is, you may find yourself being embarrassed because the patient is demanding for something and you feel that they are going beyond their limits. Then they tell you, I'm a patient expert and this is my right. You know, so we need to understand patient engagement, patient co-creation. And then we need to keep updating our ethos and branding and rebranding, keep rebranding ourselves. You know, it's very, very important that we do that. And then we need to enroll in relevant global, regional, and national bodies. Remember when I was introducing ourselves at the beginning, I said we belong to this organization, that organization. These things are very, very important as a prerequisite for impact. For example, if pharmacists want to start screening for viral hepatitis and they don't belong to a hepatitis organization, then whatever they're doing will be viewed with, you know, a lot of aspersion can be cast on what is being done, and it will be viewed with ambiguity. So we need to start enrolling in relevant global, regional, and national bodies. I will not mention the name, but there's a very prominent hepatitis organization here in Nigeria that applied to the World Hepatitis Alliance for membership, and they refer them back to Nigeria that they are not members in their home country, so they cannot join the global body. So please, it is very important for requisite impact and to have the requisite voice on a global or national or regional platform that we align with organizations that are working in the area of the disease in which we want to focus. So in this case, hepatitis. Get more engaged with patient groups, engage in dialogue. You know, very, very important. We pharmacists need to engage more in dialogue. Therapeutic dialogue, that's between you and your patient. But a therapeutic dialogue is still different from patient co-creation. Co-creation means it is now the patient engaging you and telling you what he would like, and you are now in a dialogue with that patient, trying to find out what can work, what cannot work, and working with the patient as an expert. Then interprofessional dialogue too. I'm not talking of intra-professional. Intra-professional means maybe I'm in out, I'm communicating with ACPN, I'm communicating with NAIF, and so all those are intra-professional. I'm talking of inter-professional. So from one profession to the other, both within the medical setting and outside of the medical setting. Those dialogues are very, very, very important, and they help to determine the level of cooperation we get from other practitioners, the level of impact we are able to make. Now, there's also another new thing in healthcare, which pharmacists must embrace in order to retool as part of our retooling kit. It's called health technology assessment. Health technology assessment is so important. HTA and HPX is an offshoot of HPA. The HPX is the telephony part of it. Now, part of it is telehealth services and a lot of other things that are happening now. But part of the HTA is such a broad and vast digital health platform. It even goes to the extent of going into genomic medicine and so on and so forth. It's very interesting. For example, recently, I don't know how many of us, I'm not trying to promote this laboratory, but a lab in Victoria Island, they advertised that they were doing genomic testing and so on and so forth, genomic forecasting and so on. Now that's what HTA does. It helps to forecast how is this person's health going to be in 5 years' time, and what is the likely disease pattern for this person. So we have to key into it as pharmacists. And funny enough, just yesterday, a very young pharmacist who is a past president of IPSN, is a Nigerian pharmacist, called me and said he is now involved in health technology assessment. I was so happy. So in Nigeria, we already have among us pharmacists that are already embracing health technology assessment. I know quite a few physicians that are already in it. It's a very new part of healthcare, but it's very important. And after a while, those who are not embracing it will be relevant. Okay, my phone is ringing. I've got it, madam. I'll round up now. I'll round up. Thank you. Then universal health coverage. Yes, madam, I'll round up. Thank you. Universal health coverage is also a very, very important part, and primary health care, or or public health care. And we need to acquire training. You cannot say, oh, I'm in the community, so I'm a primary health care practitioner. You must go and acquire some training. Without your training, you will not be able to, you'll just be floating. You will not be able to perch your tent in one particular area, because primary or public health care is very vast, universal health coverage is very vast. Then the principles of value-based healthcare. This is so important. Value-based healthcare, if some of us noticed of recent during COVID, I personally read a few articles about pharmacies, even pharmacies abroad, that patients were complaining about them, that they were hiking prices and so on. When you talk of value-based healthcare, you're looking at the poorest person in the community and what they can afford, and you're now going to be sensitive to know whether you're going to use a sliding scale option or to use different options that will allow the best type of healthcare affordable and available to each person. So the richest man too gets what is affordable and available to him. The poorest person also gets, but it must be basic, value-based healthcare. And then we should also embrace interprofessional, synergistic, modular engagement. That means we need to learn from each other, learn the things that the others know, and also teach them what they don't know about you. That is very, very important. Now, we took this picture in a healthcare setting, in a poor, you can see pregnant women, but you see the WWCH. That was a clinic, an open clinic for the women in hepatitis, where we were screening women for hepatitis. And these are young pharmacists. All the ladies you see in this picture are very young pharmacists, and they are all members of the Women in Hepatitis Africa. So pharmacists are very relevant in hepatitis, and we must. So I'm rounding up now with this call to action that pharmacists should train, retrain, and develop each other. We should also get engaged in research and surveillance, and we need a dedicated funding for prevention of mother-to-child transmission of viral hepatitis. I know that there's a foundation, there's a pharmacy foundation. So that foundation can embrace PMCCT as an offshoot or as part of a call to action after this meeting. And then the availability of birth dose vaccination for new babies. I think the PSN can mandate a happening as a call to action to make sure that all hospital pharmacists take it as a point of duty to embark on embracing commodity security and making sure that those essential commodities are available in the health system. Then multidisciplinary collaborations are very important, and I'm sure PSN is already doing that, but I'm sure they'll be happy to do many more of these through the foundation. And then awareness creation for hepatitis, awareness creation, advocacy, screening, and vaccination is very, very important. And in the process of doing advocacy, screening, and vaccination, you must also link people to care. If you don't link them to care, the WHO is saying that what you are doing is ambiguous. They said it at the meeting today again. And the hepatitis CSO Remember, the PSN is a CSO, it's a civil society organization. So hepatitis CSOs and CSOs that are doing anything on hepatitis should work with government at the community level and also collaborate with one another. And I'm showing a picture here that shows that collaborations matter. For example, this was one collaboration between a pharmaceutical company, the community, and then us. And if you don't get the buy-in of the community, they're not going to turn up. If they turn up, they're not going to cooperate with you. This was a screening and vaccination exercise, and this is the woman leader in that community. Now, when we were marking World Hepatitis Day last year, the emphasis was already on mothers. We are mothers from around the world. We want the best for our kids and so on. And you see, we had this. Madam, I will round up now. Thank you. So, so I just wanted to round up with a slide that shows pharmacists, real pharmacists, and the work they've done on hepatitis. I'm mentioning Mrs. Apa of Nigerian Ports Authority, who is the head of medical, and she has run a very, very buoyant advocacy, awareness, screening, and vaccination program with linkages to care and follow-up, and destigmatization, because there is a lot of stigma with viral hepatitis. Pharmacist Mrs. Rosario Agbim is running a program, and she facilitates linkages to care. I also talked to her about following up on patients and destigmatization. And of course, Dr. Bisi Bright, a clinical pharmacist who has done quite a lot, is an authority in viral hepatitis. And then one of us is working with special populations, which is very commendable. And I think it needs to be noticed and recognized. Dr. Motosho in Abuja, who is running the Hepatitis Zero program. He's a pharmacist too. So thank you very much. Pharmacists should learn to work with low income, regular women, high income women. You see to the left of this screen is a low literacy, low income woman. To the right is just a regular educated woman. So thank you very much. I have not been allowed to read my conclusion. Please, madam, let me read my conclusion. You didn't tell me you will not give me an hour. I'm not going to up to an hour. Thank you. So please, let me quickly round up. I'll quickly conclude by saying that pharmacists have a key role to play in the hepatitis response, and the new global health sector strategy on viral hepatitis elimination, which was quickly revised in the past 6 months because of COVID. So we need to educate ourselves and bring ourselves up to date on that. The new global health sector strategy should be immediately embraced, and pharmacists should not wait. We cannot wait to see every baby vaccinated, every pregnant woman screened, and every Nigerian vaccinated. Thank you very much. God bless you all. Thank you for listening. Madam, I'm done. Thank you. Mrs. Light, I apologize if I took part of your time. Things just went awry today. Thank you. Yes, thank you.
Okay. I would like to start by saying good evening, everyone, and happy World Hepatitis Day. I bring greetings from Mega Life Sciences Nigeria Limited. And today, I would like to just do a reminder on Livolin, the 3-in-1 liver protector, in the next 10 minutes, 10-15 minutes. Livolin, the 3-in-1 liver protector. Please permit me to stand on existing protocol. From all that has been said, we know that oxidative stress takes a toll on the liver, and oxidative stress is what actually leads to the damage. In alcoholic liver damage, in drug-induced liver damage, in virus-induced liver damage, and in environmental toxin-induced liver damage. So we can see that in liver disease of various etiology, there's a common thread. And that common thread is oxidative stress. And oxidative stress is the major trigger of hepatic damage and liver diseases. From what Prof said to us earlier on, not everybody that is exposed to hepatitis will come down with a severe illness or would progress to cirrhosis or cancer. However, the pathway that leads to the destruction of liver cells, cirrhosis and all, is oxidative stress. Oxidative stress is regarded as one of the pathological mechanisms that results in the initiation and progression of various liver diseases, such as in chronic hepatitis, in alcoholic liver disease, and in non-alcoholic liver disease. That is the common thread. And you also have hepatotoxicity with anti-TB therapy. We also have in HIV medication. And there's also co-infection with hepatitis C virus and HIV. So in a lot of these situations where the liver is damaged, oxidative stress is the common thread that damages the liver. I'll pay particular attention in viral hepatitis. Livolin will not eliminate the virus, or supplements such as Livolin will not eliminate the virus. However, the reaction that leads to damage of affected liver cells takes place on the cell membrane, and it is oxidative stress related. Livolin FOD helps the liver to fortify the cell membrane, to stabilize the liver cells so that they are not massively damaged, as shown through many clinical trials. So Livolin will not eliminate the virus. Why give Livolin? Why prescribe? The immune response to the virus is most critical for infectivity. Livolin FOD helps to strengthen the immune system and improves the drug effectiveness. Livolin FOD helps to reduce high relapse rate. When you're giving other medications, Livolin FOD helps to reduce the relapse rate. In viral hepatitis, the damage to the liver starts with oxidative stress and damage to cell membrane phospholipids. The ingredients in Livolin FOD help to reduce oxidative stress. And also, number 4, antiviral medications, all the lamivudine, adefovir, they are not without side effect. And this side effect, again, is due to oxidative stress. So whether you are giving medication, antiviral drugs, or you are watching, you need Livolin in all cases, and liver disease of various etiology. So Livolin supports the vital functions of the liver by providing phosphatidylcholine, vitamin B1, B2, B6, B12, nicotinamide, and vitamin E, especially phosphatidylcholine. The liver needs antioxidants to deal with free radicals that cause this oxidative stress. Livolin provides vitamin E, which is the body's principal fat-soluble antioxidants. The liver needs hepatotropic nutrients, especially the methyl donor groups, such as the B vitamins, B6, B12. Livolin provides these hepatotropic nutrients. The liver needs building blocks to regenerate. Ladies and gentlemen, phosphatidylcholine is the building block of liver cell membranes. The liver is made of 85% phosphatidylcholine, and that is what it needs to regenerate itself. Livolin FOD provides the liver with phosphatidylcholine. So in prophylaxis or treatment, in liver disease of various etiology, Livolin works. In treatment of drug-induced liver injury, in tuberculosis, in HIV/AIDS, in viral liver damage, such as with hepatitis, hepatic injury in viral hepatitis, Prevention and treatment of alcoholic liver damage. Livolin is the 3-in-1 liver protector. It's also good in neurology and in oncology. And the recommended dose is 1 capsule 3 times daily or as directed by a physician. And what is the physician looking at? Am I preventing, in which case I can give prophylactic dose, or am I treating a liver that is already showing signs of liver damage with elevated liver enzymes? So dose 1 capsule 3 times daily or as recommended by the physician. And that is Livolin, the 3-in-1 liver protector. I'd also like to introduce some other mega products useful in liver disease, such as Usolib. Usolib is a ursodeoxycholic acid for gallstone dissolution, especially when the gallstone is small and it's not radiolus, transparent on radiology. In cholestatic liver disease, in primary biliary cirrhosis, and in gallstone prevention, we have ursodeoxycholic acid or Usolib from Mega Life Sciences. Gallstone dissolution, gallstone prevention, non-alcoholic fatty liver disease, primary biliary cirrhosis, and intrahepatic cholestasis of pregnancy. Usolib from Mega Life Sciences Nigeria Limited. I think we are the only brand with ursodeoxycholic acid. We also have Barol, which is our rabeprazole brand, the best in its class proton pump inhibitor. Mega Life Sciences, we have Barol capsules and we have Barol injections. So you can give in various, I know you know the advantages of rabeprazole over omeprazole, lansoprazole, and the other proton pump inhibitor. Mega Life Sciences, we also have Gasgo for fast gas relief. It contains 200 milligram simethicone for eliminating gas in babies, adults, and children. Excessive gas removal. It coalesces the gas and facilitates its removal. Ladies and gentlemen, once more, remember Livolin, the 3-in-1 liver protector, Usolib, ursodeoxycholic acid, Barol, the best in its class proton pump inhibitor, and Gasgo, simethicone for gas relief. Thank you very much for giving me your time. I'm grateful. Bye. Thank you. I'm done. Hello. Hello. Okay.
Get him to wear this cap. I don't know how much I would have paid